We are live. Welcome to episode 2 of the Denver Prevention Training Center Summer Learning Series. We thank you for joining us today. My name is Ty Edward Few. I use he, him pronouns. I'm the Associate Director. If you joined us for episode 1, thank you. In that episode, my friend and colleague Helen Burnside and I talked about the history, the services, and the programs of the Denver Prevention Training Center. Today I'm with my friend and colleague Quiana Stallsworth. Quiana, please introduce yourself.
Hello, everyone. Like Ty said, my name is Quiana Stallsworth, and my pronouns are she, her, hers. I'm a workforce development specialist with the Denver Prevention Training Center. And I am excited to participate in the second summer learning series. Today, we're going to be talking about responsible data practices. At the Denver Prevention Training Center, it is our goal to present data humbly. We know and acknowledge that numbers do not tell the whole story. When examining and discussing data, it is critical to note that people with lived experience has multiple layers of identity which can affect their access to high quality health care. The Denver Prevention Training Center commits to pairing data with lived experiences to inform policy, drive systems change, and to improve health and well being for all, while maintaining trust, transparency, and accountability.
So, data drives all that we do in healthcare. It influences who we screen, the diagnostic tests that we do, and the medication that we give people to treat them. However, when we examine epidemiological data, we analyze rates of infection, trends over time, and those numbers reflect systems, not people.
So during this episode, we described Denver Prevention Training Center's responsible data practices. We discussed the data practices. We will use syphilis as an example to illuminate and clarify.
So we're gonna share a screen a little bit, and we're gonna show you some PowerPoints so that we are able to really get into the heart of this issue. So we're going to really look at 3 foundational data principles or data practices for the Denver Prevention Training Center. And just like life, we are having a problem displaying our PowerPoints. But we're going to share these in a few minutes with you, and you can look at them as we go. So let's talk about this. So when we talk about responsible data practices, we have 3. And we'll just talk about this. So we recognize that systemic, social, and economic barriers impact health outcomes. That is the first practice. We acknowledge that health outcomes are worse for communities impacted by societal barriers. That is the second practice. And then when we talk about individuals, we use a strength-based approach. We talk about variations in health outcomes, we use a systems level approach. Why do we do this? We do this to avoid judgment, blame, and stigmatization of individuals and communities. So let's talk about this a little bit more. The Denver Prevention Training Center has really had these 3 foundational data practices that really support our ability to discuss data in ways that really describe populations and avoid really stigmatizing individuals and communities with languages. These practices are designed to promote conversations with colleagues and community members about how data is analyzed and explained. The Denver Prevention Training Center believes that continued learning and conversations about these data practices will improve over time. And I'm going to quote a good friend of mine, Dr. Randy Miles, Chief of Research and Head of Breast Imaging here at Denver Health. He says all the time that innovation without inclusion is an illusion. So this is how we're going to roll today. We're going to explore these three data practices. I'm going to talk about practice one, and then Quiana's going to talk about practice two and three. So let's look at this first practice. Practice one, we talk about this. We recognize that systemic barriers, when we talk about these systemic barriers, we're talking about social and economic barriers, other things in the environment have an impact on health. So I'm going to give you some questions to reflect on. So let's think about this. When we talk about those systemic, social, and economic barriers, we're talking about external factors. So those external factors influence health, period. We want people to know that. We want people to understand that. And they show up even before someone enters a clinic or an emergency room. So let's think about this. Healthcare organizations, clinicians, and health departments that are providing care and treatment of HIV and other sexually transmitted infections, these external factors are influencing the communities that you serve and partner with. So let's think about some of these factors. So there's some social factors. Some of those social support factors include, what do people feel comfortable with talking about sex? What's happening in their families of origin? Then also let's think about people's income level and what they need to really survive in an environment. We live in the city of Denver. You need a car to get around here. So do people have transportation to get to an appointment to talk about their sexual health? If they can get to that appointment, will their job give them the time off to really prioritize their health? Then let's think about community safety. Each of us live in different communities. These different communities are impacted by things like race, the schools in that neighborhood, educational attainment, income level. Take those things, combine them with or compound them with what physicians do, and then combine them with other external factors that impacts health, right? Overall. So I want to ask you questions. Do people feel safe in their community? Do people feel safe coming to your organization? Though another name for those external factors are the social determinants of health. You've heard people talk about them before. The Centers for Disease Control and Prevention have defined those as the conditions in places where we live, where we learn, where we work, and where we play that affect a wide range of health and quality of life risks and health outcomes. So those social determinants of health have the ability to impact 80% of our health. I'm going to say that one more time. The social determinants of health, where you live, where you work, where you learn, where you play, impact 80% of our health. So due to those factors, remember, let's go back to practice number one. We're talking about systemic, social, and economic factors. Those really impact our health. And in many conditions, because of where people are living, where people are learning, where people are working, where people are playing, those external factors have the ability to contribute to negative health outcomes. So we call them adverse health outcomes. So to tackle those things, we must really think about what those things are and how those things interact with our patients, because they are encountering them every day and they impact health behaviors and health outcomes. So as you're thinking about how those are impacting people's health, bring that thinking into where we think about data collection and data reporting. Health disparities are not solely the result of an individual behavior or community behavior. Disparities in the data that we see are the result of the systems that we live in, that we learn in, that we work in, and that we play in. Systems are a huge contributor to health disparities and why they exist. So that's practice number one. Quiana's going to talk about practice two and practice three. Tell us more, Quiana.
Absolutely. So, thinking about what Ty said, that 80% that drives our health outcomes, now the patient or the client is in the clinic. So, our practice number two is we talk to people, when we talk to people, we use a strengths based approach. When we talk about disparities, we use a systems level approach. We do this, as it stated earlier, we do this to avoid judgment, blame, or stigmatization of individuals and communities. So, first, we're going to talk about a strengths based approach.
Mm-hmm.
We apply strengths based approach when working with our patients or clients, emphasizing their capabilities and potential. And I think it's important to emphasize their capabilities and potential.
As strengths.
Yes. And so, what does it mean to use strengths based approach? So, strengths or assets based approaches are internally focused, building upon the aspirations, innate strengths, and opportunities and resources of individuals, families, and communities, serving as the foundation to build upon well being. So, why do we use this approach? Thinking about how we use it to avoid shame,
Yes.
blame, and judgment.
Mm-hmm.
So, of individuals or communities. And so, many of the ways we talk about recommending or recommended certain items, we think of it in using a deficits based approach. So, that is the should language that we do.
Mm-hmm.
So, you should be exercising this many times a day. You should be, getting tested for STIs. You should be using condoms anytime you have penetrative sex and things of that nature. That shoulding means that we're telling people that it's an approach where we're telling the client that they aren't doing something enough, which causes negative feelings
Mm-hmm.
as well as some feelings of shame.
Right.
And so the strengths based approach is person centered,
Mm-hmm.
and it's not focused on the cause of the problem, but instead on past successes, on what a client can and will do to enhance their health and well being in the future. Yeah.
And that strength-based approach really invites somebody in to the process of improving their health.
Absolutely, absolutely. And thinking about this, so we're going to put this into an example. A stigmatizing example would be you're in a prioritized population for syphilis. And so we're going to screen you and we're going to test you for syphilis today at your prenatal visit. So think about the words that are part of that stigmatizing example. Let's look at the strengths based example. Thank you for choosing us to be part of your prenatal care. As part of your care, we routinely test all persons who are pregnant for syphilis and other STIs to keep you and your pregnancy healthy. Just thinking about that strengths based example already, what comes to mind for you?
For me, that strengths-based example really starts to invite me in.
Yep.
It doesn't make me feel like just because I live in community X or I live in zip code X that something's going to happen to me. It does think about all the things that I did to get there, and so it makes me feel, even though I'm currently not pregnant,
Right.
It does make me feel like I'm doing things to have a very positive health outcome.
Yeah. And I even like thank you was the first two words. That means a lot. And so, in thinking about the stigmatizing example, it makes it seem or the patient is automatically at a high risk for syphilis. In addition to that, there's already a stigmatizing language around that's very judgmental, which actually could lead to perhaps the patient not even returning for care.
Mm-hmm.
On the other hand, the strengths based example, it was affirming, and Ty, you mentioned it. It made you feel good, and it promote an example of a well-being and also a patient-provider relationship, because we do want them to come back. And so this example focuses on well-being rather than disease prevention.
And the one thing I want to say about this, I would love for us as a health communities, people in public health, people who work in healthcare, to really stop talking about you are high risk for something, because it does not always result in promotion of health. What it really does for many people is shuts people down. And so that
Mm-hmm.
people, it makes it hard for them to then really take in what they could do to improve health. So some of that language, we know that we want to really alert people to things that are happening in their environment that they can take hold of. But when you talk about high risk or risky behaviors, sometimes that does more damage than good.
Absolutely. Those words, single words like risk, really does drive a rift between the patient and the provider. Next, we're going to talk about taking a systems level approach. So, we take a systems level approach when collaborating with colleagues and delivering training, considering the broader structures that influence our work. And so, going back to the numbers and charts, remember, the numbers and charts only show one side of the story. We encourage clinicians, providers, healthcare organizations to examine the systems behind the numbers.
Mm-hmm.
A systems level approach identifies structural influence and factors to access in terms of testing, provider workflows, and data reporting practices. And that influences how sexually transmitted infections and other health issues are detected.
So let's just stop here and let's go back to practice number one.
Mm-hmm.
This is really getting at that concept that we talked about in practice one, that there are systemic,
Mm-hmm.
social, and economic factors that impact health. And what you just described with the systems level approach encourages organizations to really think about those systems. I just wanted to put that in there.
No, thank you, Ty, because that's something that should be highlighted quite a bit. And so, thinking about the stigmatizing example of systems level, because Black and Latinx mothers have high rates of syphilis that is passed to their children during pregnancy, we need to screen for syphilis during pregnancy. So there's some keywords already right there that are ringing some bells that are stigmatizing. Let's give a systems level example. Black and Latinx women may experience limited access to preventative care. Here we make sure to screen all patients who are pregnant for syphilis and other STIs. So, what stood out in that example for you?
Once again, under the systems level example, it really thinks about the systems that are impacting health for black and Latinx women, right?
Mm-hmm.
Because the numbers alone don't tell the story. Let's go back to this practice number one, that there are these factors that are happening in the world, right?
Mm-hmm.
These societal things that are impacting health. And so when we think about the needs of the communities that we serve, if we don't consider the systems in which people live, learn, work, and play, we are missing a big contributor to health disparities. Is that the
Absolutely.
answer that you were looking for?
That is totally
Because
the
that's the only
answer.
one I got.
That is the answer I was looking for. So, looking at this from the systems level approach, this is an example of a health disparity within a particular demographic group and the need for syphilis screening in this group. That's the focus. And so the stigmatizing example makes it seem as if this group specifically is inherently at a higher risk for syphilis. The systems level example, on the other hand, focuses on how systems may affect groups of people.
Mm-hmm.
And the example is less stigmatizing, and you said it earlier, more inclusive.
Right.
And so when we think about what strengths the individual has, and we can use it to empower their health, the strengths based approach identifies and highlights an individual's assets, using them, using them to help themselves become as healthy as possible. This makes me think about how individuals can have more autonomy in their health care and then make better decisions about their health. And so we encourage clinicians, healthcare organizations, and health departments. Review your intake forms and your documentation to identify areas that could be changed or reframed with a strengths based approach in mind.
So now that was practice number two. So practice number one was thinking about the systemic, the social, and the economic factors that impact health. Practice two requires us to really use a strengths-based approach when talking to a person.
Yep.
But when we think about communities, to use a systems level approach to avoid blame, judgment, and stigmatization. Tell us about practice number three.
Absolutely. So we strive to include the lived experience and traditional knowledge of community members into population health analysis because the community health experience is complex. And so to honor that complexity, practice does it. Let's practice on focusing on who's telling the story. What does this mean in practice, though? So we measure who and what we value. How can we ensure that those who are underrepresented identities are counted and included when we think about data? This is where the importance of having people with lived experience represented in quantitative data. It can provide a much needed context that reduces stigma and offers opportunity to work with communities in reducing disease burden. So when data isn't based on the most those who are experiencing intersections of health and social issues, it's not telling the stories of the society that we live and work in. We need to update and integrate alternative types of data to complete the data story.
So that's practice number three. So practice number one was thinking about the factors that impact health. Practice number two was really thinking about using strengths-based approach when talking to people and systems level approaches when talking about communities. And this third practice really gets you to think about who's telling the story? What do these numbers mean? Go beyond the numbers because the numbers tell one thing. But we talked about this concept, or you spoke about this concept of intersecting health concerns. And so when you think about that, think about what that could mean. So there's more than just the number to the story.
Yes.
So that, thank you, Quiana, for reviewing that. We've just gone through the responsible data practices from the Denver Prevention Training Center. And we wanted to give you three things to take away. And these are not difficult things, these are not hard things. We talked about these things. These three things are really just these foundational practices. So number one, here we go again. Clinicians, healthcare organizations, and health departments must really, really, really acknowledge that health is really impacted by what we have called these systemic, these social, and these economic factors. That's practice number one. Likewise, clinicians, healthcare organizations, and health departments must integrate a systems level approach to population data and intervention efforts to really avoid judgment, blame, and stigmatization. This is practice number two. And the final practice is data does not tell you the whole story. Data just gives you the numbers. That's practice number three. So those are our three practices. Now, this is an opportunity for the questions and the answers. This is the part where you get to really show us how much we were clear or what we need to express again. So now I'm going to ask our producer, Dane Roper, to shoot us over some questions. Producer Dane, what's happening in the Q&A?
Yeah, a couple questions. So the first one, I think something that stood out is, Ty, when you mentioned, don't use the phrase high risk when speaking to patients. And I think there's some question around how do you sort of, if there's some urgency, right, and like the need for testing or something like that, how do you communicate that urgency to a patient through that sort of strengths-based lens? Does it ever get lost, that kind of urgency? Is there a risk there?
So let's start with this. We can give you sentence stems of things that you can do, but the most important thing you can do is really start to explain why there's an urgency for the testing. You could talk about behaviors that people engage in, but people are more than just behavior. So let's give you an example. For a long time, with dealing with HIV, black gay men were thought as this vector of infection. So black gay men would go to conferences or they'd go see the doctor, they'd go to the club, and then they would be told, you're at high risk for HIV, you're at high risk for STIs. And so people would walk around feeling like that their whole sexual health, their whole romantic health came down to just an infection. When we looked at the data, we understood that why there's a high risk. And so we stopped talking so much about risk and said, there are some factors about being a black gay man that you need to understand. Those factors make it urgent for you to consider your sexual health in different ways that other populations may not. Takes a little bit more time. It's not as straightforward as saying you're at high risk, but really what it does is that it puts the person first. It looks at the strengths that that person has, and then it also considers the systems in which that person lives in, because what the research told us was that when it comes to sexual attraction, black gay men were at the bottom. So that black gay men were in sexual networks where there was a higher incidence of HIV because of their sexual networks. So it wasn't that their behavior was innately risky, it was just the networks, the structures where people live, work, play, and learn. I'm rambling, but I think that
No, that's
helps.
great. And we have actually a question that I think goes nicely along with it, and it's, can you give us some of your thoughts and maybe ideas around approach to how we help clinicians kind of maybe adjust some of their behavior and the words they're using when they are caring for patients?
So I will say, I'll start with this and then I will hand it over to my friend and colleague. The Denver Prevention Training Center exists to help clinicians learn this and practice this. So that's just a plug. It's not a shameless plug, it's just a plug for what we do. We offer classes in that. But Quiana, do you want to give some more specifics?
Yeah, I really love that question because thinking about when we're talking about person first and human first language, the first thing that came to mind was we have a Words Matter campaign where we talk about how we always focus on the person or the human in front of us first, and then the condition and why they're there second and third. And so focusing on using those skills where we can talk about the Words Matter campaign. Also at the Denver Prevention Training Center, the clinical regional team, we worked with physicians and healthcare and clinicians talk about how to center person first care and use person first language.
We have a course called Taking an Affirmative Sexual History. We recommend people do that so that they understand how to really talk about this in ways that are human-centered and person-centered. It's something that we encourage physicians and clinicians to practice because it is not something that you do once and then you're good. You're going to have various circumstances, new populations, new new things for you to consider.
Great. I think there's one more question that I see, and this is going all the way back to practice number one, talking about social determinants of health. Are there any social determinants of health that you feel maybe aren't talked about enough and that you see really impacting patients that maybe should be brought to light more?
Mm. So I'll give one, and I think maybe we have different ones, but we can really talk about the neighborhood and the built environment. We don't do that enough to think about how that particular social determinant really impacts health. I'll give you a great example. For years, I lived in a city in Georgia called Atlanta. You may have heard of it. It's the crown jewel of the South. I will make that claim. If you have a problem with that, you can email me at my following email address, which I'm not going to give you. But in Atlanta, there are so many wonderfully new constructed neighborhoods without sidewalks. So where do people walk? They walk in the street. What else is in the street? Cars. Great example. We don't think about the built environment enough. Another thing, there have been so many reports around the nation about the impact of communities of color and how their land has been taken and highways have been put in there. So the built environment is something to consider. So that's my social determinant of health that impacts health. Quiana, what do you have that may be different?
What I was thinking about is through the lens of a Black woman, where there are certain societal expectations of me when I think about how I need to provide for myself and matching that up with Black women statistically have been individuals who are lowest on the pay scale, as well as when it comes to healthcare. There isn't that much research in terms of Black women and their health. And the research and the physicians that are available that address Black women's needs specifically are very, very low. Going further, looking at the idea of mental health in Black women, mental health providers that are specialized in issues with Black women in particular are also very low.
Few and far between.
Yeah, let alone individuals who are mental health providers, psychologists, psychiatrists, things of that nature, who are Black in general are also very low. And so walking into that space and having sort of that cultural lack of awareness going into a mental health space is also part of this social determinants of health as well that we don't think about.
A couple of years ago, the Public Health Institute at Denver Health had a lecture series, the Sabarbaro lecture, and we spent a lot of time looking at the impact of mental health providers or the lack of mental health providers for communities of color. And that does impact the social determinants of health. I will also, we can go there for a minute, for a few minutes here.
Let's do it.
When we think about the social determinants of health, communities of color are often greatly the impact is greatly studied. The interventions are few. So it's not just for Black women you talked about. I think about Black women are the highest educated
Yes.
segment of society. Yes.
Yes.
Look it up. But when it comes to pay scale, are paid the lowest. That does impact health. I think about the recent changes in law that are impacting the ability of Black people to pursue medical degrees. And with fewer Black clinicians and providers, that means that understanding that community, because there's something that happens when I walk into my doctor's office and she's a black woman. We have a moment of,
Yes.
there's something that we understand.
Yes.
For example, we just had a coded conversation with the and the We had a whole hour's worth
You don't even know.
of conversation, right?
Yeah.
And so that is critical to really improving the lives and health of others. So we went there. It's okay. We'll go there more in session number 3. Any more questions, Producer Dane?
That's it.
All right. So thank you for joining us. Quiana, do you want to tell us where we're going to be in the next couple weeks?
I do. So, just to let you know, first of all, thank you for being part of this series. We're so glad you're here, and please continue to join us for the next 2 series, right, that we're coming up. Great. So, to learn more about our programs and services, please contact our website at denverptc.org. We are going to be at 3 conferences, so if you are going to one of those conferences, please come and visit us. The first one is the STI and HIV World Congress, and that's going to be July 25th through 30th in Montreal, Canada. The second is going to be the Circle of Harmony HIV/AIDS Wellness Conference from August 26th through 28th in Albuquerque, New Mexico. And lastly, the United States Conference on HIV and AIDS, September 4th through 7th in Washington, D.C.
All right, so thank you for participating in the second episode. Join us August 21st, 12 p.m. for our 3rd episode on targeted universalism. Before we go, we want to thank 2 incredible people who made today possible. Producer Dane Loper and executive producer Kim Weeks have made this special for us. We want to thank you. Thank you, Quiana, for joining us for episode number 2.
Thank you.
We appreciate it. We do have some PowerPoints that we will PDF and put on our website so that you can follow along with us. Thank you for giving us your lunch hour.
Yeah.
Drink some water.
Mm-hmm.
Go outside. Hydrate. And tell someone you love them, but love yourself.
For real.
Most importantly.
Yeah.
All right. Thank you.
Thank you.